Welcome to the CDC's Adolescent Immunization Webinar Series. My name is Tom Schaefer. I'm with the National Public Health Information Coalition, and I will be your host today. Joining me is Catherine Martin, Executive Director of the California Immunization Coalition, who will assist with the questions and answers after our presenters have finished. Today's webinar, An Interprofessional Approach to HPV and Oropharyngeal Cancer Prevention Education, features the Massachusetts Oral HPV Prevention Task Force, which was created to build connections between medical and dental professionals to increase HPV vaccination rates, to decrease HPV-related cancer, and to educate providers and patients on oropharyngeal cancers. As you may know, 31,500 cancers are linked to HPV each year, and the number is rising. More than 7 out of 10 oropharyngeal cancers are related to HPV infection, and the incidence of oropharyngeal cancers have increased more than 225% in the last few years and surpassed cervical cancer as the most common HPV-related cancer. Dental professionals are aware of the role of smoking and alcohol consumption as risk factors for oral cavity and oropharyngeal cancer, but trained dental professionals may be underutilized in HPV education and oropharyngeal cancer prevention. Over the next hour, today's experts from Massachusetts, they will describe steps to build partnerships with dental providers on HPV education and the importance of HPV vaccination, identify the relationship between oral HPV infections and oropharyngeal cancers, discuss ways that dental professionals can include HPV education in patient visits, including an overview of helpful resources, and finally determine the effectiveness of an HPV prevention campaign via interprofessional education and consider strategies for sustainability. Now, before we begin, there's just a few housekeeping items. As a reminder, there is no dial-in number associated with this webinar, so please make sure your speakers are connected and all participant lines are muted at this time. The webinar is being recorded and will be available online after the broadcast, as well as the slides. So during the webinar, you can ask questions by typing them into the question panel at the lower left-hand corner of your screen. Selected questions will be read aloud for the presenters at the end of the presentations. Now it's my pleasure to introduce our presenters. Rebecca Benucci is the Immunization Outreach Coordinator for the Massachusetts Department of Public Health. She plans the strategic educational outreach to providers, patients, and the larger community about immunizations, and engages outside partners and stakeholders about immunization-related topics, and coordinates statewide pediatric and adult immunization conferences and regional immunization updates. Rebecca is a founding member of the Massachusetts Oral HPV Prevention Task Force. Next is Dr. Alessandro Villa. He's an assistant professor in oral medicine, infection, and immunity at the Harvard School of Dental Medicine and an associate surgeon at Boston's Brigham and Women's Hospital and Dana-Farber Cancer Center, where he also serves as the program director of the Oral Medicine Residency Program. Dr. Villa's research interests are primarily oral HPV prevention and oral leukoplakia, and his clinical interests include treatment of oral mucosal diseases, salivary gland disorders, and oral complications from cancer therapy. Next is Dr. Rosie Wagner. She founded a family dental practice in Somerville, Massachusetts that focuses on reducing dental avoidance and shame, improving patient-provider communication, and establishing the dental office as part of a comprehensive medical home. In hosting annual immunization clinics at her practice, Dr. Wagner became interested in promoting illness prevention through vaccination. She is co-chair of the Massachusetts Oral HPV Prevention Task Force. And finally, Lisa Bennett Johnson is a research registered dental hygienist with the Oral Medicine and Dentistry Division at Brigham and Women's Hospital and a clinical research coordinator and oral examiner for the National Institutes of Health NIDCR Oral Rad Cancer Study. She teaches in both the Master of Public Health program and the Forsyth School of Dental Hygiene at Massachusetts College of Pharmacy and Health Sciences University in Boston. Lisa is also the educational coordinator and assistant grant writer for the Massachusetts Oral HPV Prevention Task Force and Team Maureen. Now I'd like to turn it over to Rebecca.
Thank you, Tom, for that introduction. It is my pleasure to be a part of this webinar today discussing the activities of the Massachusetts HPV Oral Prevention Task Force and all of our exciting educational opportunities. I fondly refer to this project as the HPV Dental Project, and I will be reviewing how the Massachusetts Oral HPV Prevention Task Force started and our central mission. As Tom mentioned, the Massachusetts Oral HPV Prevention Task Force was created to build connections between medical and dental professionals to increase HPV vaccination rates, decrease HPV-related cancers, and educate both providers and patients about HPV-related oropharyngeal cancer. We're addressing two main questions today, the why and the how. So why was the HPV Prevention Task Force created, and how was it created? I'm going to be going over the history of our group and how the members contribute to our activities. We all know that HPV infection is common. Most people do not know that they are infected. Luckily, the majority of infections clear on their own, but still an estimated 79 million Americans are currently infected, with 14 million new infections each year in the United States. And while most infections do clear on their own, persistent HPV infection, however, can cause cancer. As you can see on this slide, this is a table of the cancers caused by HPV each year. And while we may be familiar with many of these HPV-related cancers, when the task force was first started in 2015, we often said that oropharyngeal cancer would outpace cervical cancer by 2020. But you can see in this table that it already has. And HPV-related oropharyngeal cancer has now surpassed cervical cancer as the most common HPV-related cancer. And that's a really important part that we could talk to all of our patients and our surrounding communities about, to talk about the benefits of HPV-related cancer, that it is not just cervical cancer, but 6 different types of HPV-related cancers. So these are the main reasons that the Massachusetts Oral HPV Prevention Task Force was created. First of all, we know HPV cancers rates are rising. They're approximately 31,500 each year. And as I mentioned, oropharyngeal cancer has now surpassed cervical cancer as the most common HPV-related cancer. And my colleague, Dr. Vila, will discuss this more, but there is no screening for oropharyngeal cancer. And then in my immunization world, we often say that it takes a village to vaccinate. And dental providers are trusted healthcare professionals who may see their patients more often than primary care providers. They can be a wonderful addition to the vaccine advocate team. And then one of the most successful ways to talk to parents and patients about HPV is to say, if there was a vaccine against cancer, wouldn't you get it for your child? Well, there is. HPV vaccination can protect against the HPV types that can cause cancer, including the oropharyngeal cancer. Many of you may know the HPV current recommendations, which are routine vaccination can be at 11 or 12 years old, but can start as early as 9. Vaccination is recommended through age 26 for females and through 21 for males not previously vaccinated. And vaccination is also recommended for men through 26 who have sex with men or are immunocompromised. The dosing is if you get it before your 15th birthday, you can get 2 shots 6 to 12 months apart. And then you need to have 3 shots if started after the 15th birthday or with an immunocompromising condition. And I love these pictures because this is how we explain vaccines in general. You want to have the best protection before any kind of exposure. So when should the bike helmet go on? Do you want A, the bike helmet to go on before you ride the bike, B, while you're riding the bike, or C, when you've already gotten into a crash? This this shows the importance of all vaccines, that you should be getting it before exposure. And the HPV vaccine is better younger because your immune response is higher, and you only need 2 doses if done, again, before your 15th birthday, if you would start it before your 15th birthday. These are the members of the Oral HPV Prevention Task Force. It started in 2015 with connection between all of these groups, and I'm going to go over them a little in more detail. So the Department of Public Health Immunization Program right here, which I represent, as well as many of my colleagues, including my medical director, we are actively promoting HPV vaccination through many activities. And one of our main partners is the Department of Public Health Cancer Network, and our medical director is actually on the steering committee of the Massachusetts Comprehensive Cancer Control Network, and we support each other's initiatives to increase HPV vaccination rates to decrease HPV-related cancer. Massachusetts is also very lucky to have wonderful advocacy organizations that work on HPV-related cancers. Team Maureen, which my colleague Lisa will be going over in a little bit, is a wonderful cervical cancer advocacy group that has been a main component of the HPV Prevention Task Force. We are also lucky in Massachusetts that we have a strong Massachusetts chapter of the AAP, and they have a group called the Immunization Initiative, which is a wonderful partner in advocating for pediatric and adolescent immunizations in Massachusetts. And some of the dental professionals that are on the phone today, some of my colleagues, are great partners to advocate for HPV vaccination and to decrease HPV-related cancer, and they make up a big part of the Oral HPV Prevention Task Force. And then we also have a widow advocate. Jill Seaman lost her husband from oropharyngeal cancer and has become a staunch supporter of HPV vaccination and supporting all of the initiatives. And it's really important to have that perspective included in this task force because she reminds us all why we are doing the work that we are doing. Massachusetts was fortunate to receive PPHF funding to increase HPV immunization rates through several different means. One of the activities was to develop a statewide initiative with immunization stakeholders all dedicated to increasing HPV immunization rates to decrease HPV-related cancer. Out of this initiative came 2 separate groups that you can see on your screen. The immunization programs down here, and out of the larger initiative came 2 groups. You can see in the blue and in the purple on your screen. The first group, the inner group right here, is the working group affiliated with the Comprehensive Cancer Control Network. This working group is a closed, invitation-only, smaller group that is focused on certain projects to decrease HPV-related cancers. One of the projects that they took on was the Oral HPV Prevention Task Force, but a project to educate dental professionals. The larger purple area is the HPV Coalition that has come out of the HPV initiative started by the Massachusetts Department of Public Health. This group is for anyone interested in working towards activities for HPV education, HPV vaccination, and HPV cancer awareness. And the Oral HPV Prevention Task Force, while it started as a subgroup of the smaller working group under the Comprehensive Cancer Control Network, it now has expanded into our own distinction in coordination with the HPV Coalition. And so how do we do what we do? First of all, we connect. We were lucky that while I'm working at the immunization program, I was working on many HPV initiatives and found out about Dr. Wagner providing immunization clinics in her office with a retail pharmacy as a true vaccine advocate. At the same time, Team Maureen was working with Dr. Vila on different initiatives for HPV education and dental professionals. We all connected and made sure that other stakeholders were a part of the group, and we then had monthly conference calls. We would meet in person when applicable and brainstorm ideas and different activities we could work on. And then we collaborated on different projects. One project called the Genital Toolkit, which Lisa will go over briefly later, was a wonderful collaboration to have educational materials for dental providers. And then we also collaborate on various presentations like this webinar. We continue to strive to work together to really ensure that dental professionals are educated about HPV and HPV-related cancers. And with that, I'm going to turn it over to Dr. Villa, who's going to go over the overview of HPV and oropharyngeal cancers. Dr. Villa?
Thank you so much, Rebecca, and welcome everyone. I don't have any financial disclosures, and today I'm going to talk about the epidemiology of oral HPV infections and oropharyngeal cancer, and I'm going to focus on the association between persistent HPV infections and the development of oropharyngeal cancer. So head and neck cancer arises from the mucosa of the larynx, the pharynx, the oral cavity, and the nasal cavity. But today we're going to focus only on the oropharyngeal area, so oropharyngeal cancers. So when we consider the risk factors for oropharyngeal cancer, we know that tobacco smoking is the #1 risk factor, along with alcohol, and cigarette smoking and alcohol have a synergistic effect. In countries in the Southeast Asia like India, areca nut is one of the major risk factors, and then we have immunosuppression, a family or personal history of cancer. But in the past 30 years, we saw an increase in the prevalence of oropharyngeal cancers, and this is because of persistent HPV infections, specifically HPV 16 and 18. And another risk factor that has been listed by the American Cancer Society is being of young age, under the age of 45 years old. So when we look at the data that were recently published, we know that it is estimated that about 3,200 new cases of HPV-associated oropharyngeal cancers are diagnosed in women, and about 13,200 are diagnosed in men each year in the United States. And of the majority of this cancer, more than actually 70% of this cancer are associated with persistent HPV infections. So this slide shows the increasing rates for oropharyngeal cancer over time. These were taken from the SEER dataset, and we see that oropharyngeal cancers have increased since the 90s with a steady increase compared to the other cancer of the head and neck. And this is again because of persistent HPV infections of the oropharynx. And there are different types of oral HPV infections. We have high-risk types and low-risk types. Here I listed all of them. And these can cause different diseases as shown in the table. So if you look at oropharyngeal cancers, for example, the majority of these cancers are caused by the HPV type 16 and 18. During the years 2011 and 2014, the prevalence of any oral human papillomavirus infections for adults aged 18 up to 69 was 7.3%, with the majority of the infections being among males. If we look at the data for high-risk oral HPV types, which are the ones responsible for oropharyngeal cancers, we see that high-risk oral HPV infection was more prevalent, again, among men with 7.3, as the overall prevalence of high-risk oral HPV infection was about 4% in the general population. So in this slide, we want to show what is my risk of having an oral HPV infection. This graph shows the prevalence of oral HPV 16 and also any oncogenic oral HPV infection by risk group. In the very low risk group, oncogenic oral HPV was similar among smokers and non-smokers. And in the low risk group of women, oncogenic oral HPV prevalence was about 1.5% among women with 2 or more lifetime oral sexual partners. In the low-risk group of men below here, we see that oncogenic oral HPV prevalence was 2.8% among men with 0 or 1 lifetime oral sexual partners, and was higher among men who did not smoke and had from 2 to 4 lifetime oral sexual partners. And then in the medium risk, we have men with oral HPV-16 prevalence that was about 7%, and among men who smoked and had 2 to 4 partners. And this prevalence is higher, and it goes up to almost 15% in men who do not smoke and had more than 5 partners. So what is telling us? This slide is telling us that the number one risk factor for acquiring an oral HPV infection is having a high number of oral sexual partners. This table comes from a study on the HPV natural history among men enrolled in the HPV infection in men study, and we show the prevalence of the incident rates of HPV infection by anatomic site of infection. And as you may see, the median time to clearance of oral HPV infection was about 7 months. This is to tell us that we could be positive today for an oral HPV infection, but our immune system does a good job usually to clear the infection, and it takes about 7 months to clear the infection completely. So this study is the first study that demonstrated that HPV-16 detection preceded the incidence of oropharyngeal cancers. So what they have done in this study is that they followed about 97,000 participants that were cancer-free at baseline, and they obtained mouthwash samples in 2 prospective cohort studies, and they followed these patients over time, and the incident cases of head and neck cancer were 132 cases that were identified during an average time of 3.9 years in both cohorts. And oral HPV-16 detection was associated with incident oropharyngeal cancer with a positive association for squamous cell carcinoma of the oropharynx. So this is the first study that really demonstrates that HPV-16 detection precedes the incidence of oropharyngeal cancers. When we look at this graph, we also see that patients who have inactive genital HPV infection are at a higher risk of developing also an oral HPV positive infection. So if we look, for example, at this graph here on the left, where we show the prevalence of oral HPV infection overall, we see that if men have also a genital HPV, the prevalence of oral HPV will be way higher than in men who do not have any genital infection. And the same is for women. So for example, men, if they have an HPV positive genital infection, they will have, there is a concordance for oral infection of 19.3%, whereas the infection rate dropped to 4.4 in the oral cavity, oropharyngeal cavity, when there are no genital infections in this population. This figure summarizes the natural history of HPV positive oropharyngeal cancers. The oral mucosa is exposed to HPV, and when the infection persists over time and it's not cleared by the immune system, the HPV cycle starts, and its persistence can lead into the development of HPV-related oropharyngeal squamous cell carcinoma. So can we test for oral HPV? Well, there are currently no screening tests or treatments for oral HPV infections. Most of the infections we saw that they clear in 1 year spontaneously and do not require any treatment, but some infections may become persistent, especially in immunocompromised patients or active smokers, and only routine HPV testing for oropharyngeal is recommended only for oropharyngeal squamous cell carcinoma and head and neck cancer of unknown primary. And the role of testing is to provide just prognostic information or to allow for localization of unknown primary lesions. And the HPV tumor status does not change current treatment or surveillance guidelines, except in the context of new clinical trials for these cancers. So to summarize, we saw that persistent high-risk HPV infections, primarily HPV-16 infections, are associated with oropharyngeal cancer. and oral sex remains the major risk factors for HPV oral infection. And to date, there are no screening tests available or recommended for oral HPV. I'd like to turn it over to Dr. Rosie Wagner, she's going to talk about HPV-related oropharyngeal cancer and the patient-provider relationship. Rosie?
Thank you so much, Dr. Vila. As a private practice dentist, it's my role to bring oral health information to patients and communicate about oral disease and prevention. I'll be presenting recommendations for useful and accessible conversations about HPV and HPV vaccination. Though I'll mainly focus on the dental provider-patient relationship, these communication tips are useful for anyone in the healthcare and public health fields. And I have no relevant financial relationships to disclose. Dentists have a responsibility to help prevent head and neck pathology, and we're well educated in this part of the body. We have close relationships with our patients and can make an enormous difference in educating patients about HPV, which is a topic that many might not know too much about before attending their dental visits. We're also accustomed to referring patients to specialists, so we're already practiced in referring them to get HPV vaccination. Dentists, hygienists, and assistants are constantly talking with their patients. We have a much closer relationship than in many other types of healthcare settings, and this is also consistent among PCPs and pediatricians and other diagnosing types of providers. Patients tend to be willing to talk about many aspects of their health, lives, and wellness, and the dental visit has a high amount of conversation. Some healthcare providers might have some initial reluctance about talking about HPV. Reasons might include not knowing too much about the topic, not being versed in including vaccination history in a comprehensive health history, discomfort with discussing STIs, limited time, limited scope of practice concerns. Let's go through each of these concerns individually to help offer some resources and reassurance for providers to feel more comfortable in talking about HPV. In terms of not being discussed in health history, it's quite easy and important to include vaccination status in a patient's comprehensive medical history. I'll go through my example medical history and how we do it in my practice, but I do recommend that all providers across the different spectra of medicine include this in interviewing patients. You're all here listening to this education, and there's a lot of great resources out there, so it is important to become educated in any topic that can help be preventive for our patients. In terms of discomfort with discussing STIs, transmission is not as important an aspect of discussing HPV as much as cancer prevention through vaccination. And also the virus is very commonly cleared on its own, so that can be a part that's minimized or removed from a conversation, especially if that's your major barrier to bringing up the topic. It doesn't add a significant amount of time to appointments. It's included in the comprehensive health history taking, as well as in educating about different forms of head and neck cancers in general with the patients. And it is certainly, thankfully, within our scope of practice to understand risk factors and all forms of cancer of the head and neck, including HPV-related oropharyngeal cancers. I recommend that the medical history form be the first time that HPV is mentioned by including a general questions about immunizations. This can be adapted to both adult and pediatric comprehensive medical history forms. I find in my practice, conversations about HPV work best with verbal medical history taking. And I encourage all of you to consider this because the back and forth really allows for a deeper conversation. In my particular office, the patient's relaxed against the neck pillow. They're facing away from the provider who has access to their forms and the internet at the same time. And then we go through a series of questions, allowing me to immediately extrapolate on information they provide. Since we're already having a two-way conversation, I include questions about different body systems, social health, lifestyle, choreography. So adding this question about HPV immunization has an appropriate role, and thus far, no patients have been surprised that I've included it in the health history. This is an example form that I use at my office. And as you can see here, we ask a series of questions. Do you have any gastrointestinal disorders, any kidney or liver disease? We ask if you feel safe at home. We ask about food security and our resources needed for groceries. And also, are you current on your immunizations, including HPV? And so this becomes a very effortless and accessible way to bring up the topic. And in many cases, patients will say, oh, tell me more about that, or what is HPV? And they've thus raised the topic for you and are a captive audience and want to learn more about it. So that's why this is a great opportunity for first bringing up the subject. This is an example of our pediatric medical history, and it's the same thing here, a little simpler. We're simply going through the questions and then asking, is your child current on their immunizations, including HPV, if the child's aged 9 to 26. So this is an example of how we do it, but it becomes very adaptable. Other good times to raise the topic, and again, if they respond that they want more information about vaccines in general, you can link them to the CDC's vaccine link, which has some very visually and audible accessible PDFs and text links to the current vaccine schedule. Other opportunities to raise the topic: when performing the oral cancer examination and asking about signs and symptoms, that's a useful time to have an educational conversation about HPV. But it's important to remind patients that HPV is associated with oropharyngeal cancer rather than oral cancer, and that the best way to prevent HPV-related cancers is by getting vaccinated at ages 11 to 12. Patients may also ask why we are asking questions to check about throat and pharyngeal symptoms, and that's also a good time to raise the topic. So in explaining HPV itself, keep the explanation simple, focus on the virus and prevention through vaccination. That's the message that's important to get across, and patients tend to respond most effectively when they know that it's a common virus that can cause cancer, and particularly that there's a vaccine that can help prevent their children from getting cancer. Remind them that penetrative sex is not required to transmit HPV, and that most strains are cleared by the body's own immune response. It is very difficult to prevent transmission, and it doesn't always cause cancer, so avoiding anything that shames or scares parents and patients is crucial. And this is why it might be a good idea to decrease the importance of transmission, because we're focusing on preventing the cancer, referring for vaccine, and educating about HPV in general. If you approach the conversation with the sense that HPV already exists and the point of the conversation is to educate about HPV-related oropharyngeal cancer, you're setting the attitude that you care more about prevention than about judgment. So explaining the HPV vaccine, simply say there's a vaccine that protects against this cancer-causing virus. It works really well, is one of some vaccines that can prevent cancer, and a written referral is ideal here, particularly one that encourages parents and patients to let you know when the series is completed. There are available resources online that have these referral forms, which we'll go over in a bit. You can write your own. You can use your already established referral system to make sure that the vaccine series has been completed, whether it's a 2 or 3 vaccine series. It's also a good idea, this is important, to have patients let you know if they or their children are turned away from getting vaccinated, so you can follow up and see that provider's reasoning. This can lead to opportunities in educating other providers. Though dentists cannot administer vaccines in Massachusetts, if you remind parents to have their pediatrician or family doctor check on other vaccines, you're including HPV immunization in part of an overall vaccine discussion, and also not highlighting that you're referring them simply because you're worried about their child contracting an STI. You can refer them to whatever immunization provider is appropriate for that patient, and then remind them that unfortunately dentists cannot administer vaccines in the dental office. Remind them that the vaccine is recommended for ages 9 through 26 for women and 9 through 21 for some men, and it's up to the immunizing provider to make recommendations for other populations. Studies consistently show that a strong recommendation from you is the single best predictor of vaccination for any vaccine, including HPV vaccine. That's explained on this next slide. Data from 2014 shows that nearly 15% of parents who said they would not be getting their child vaccinated stated not receiving a recommendation as one of the top reasons. So us as providers can make an enormous impact here. Sometimes there are patient concerns about both the conversation and the vaccine, and general suggestions for this is that it's important to not send a lot of data to the patient or cite studies if that's not the most effective way that that person comes to conclusions. General reassurance that you would get the vaccine for yourself, your patients, your children, that you have been vaccinated yourself, anything like that that makes it more accessible to the patient is effective. And importantly, take the shame away from HPV. Remind parents that you're focused on preventing cancer for their children, not blaming them on their viral status, assuming that a viral status will occur, discussing risk factors. You're simply trying to educate and prevent. And you may reassure them that most strains of HPV are cleared naturally by the body, but that some types of persistent infection can lead to throat cancers. Common questions that I've received as a provider from patients. These are some of them here, and I'll go through some of the ways that I found helpful in responding to them. Should I get vaccinated as well? Recommendations outside of the CDC guidelines or outside of the scope of this talk, but refer patients back to their physician or pharmacist or immunization provider to see about that. Currently, the recommended ages are, as we went over, 9 to 26. Thankfully, most strains of HPV are cleared naturally by the body. And if that's generally responding to that they didn't know that it caused throat cancer, reassure them that most are cleared, but that some persistent strains can contribute to these kinds of cancer. There has been a lot of HPV in the news. It's a very common virus, has an effective vaccine, and it's important to be taught at all levels of the community. Remind them that dentists cannot give vaccines, but you can refer them to the appropriate provider. If they're wondering if the child is too young, remind them it's important to get vaccinated as early as possible to have immune protection before exposure ever occurs, and that studies support that it will not make your child more likely to participate in sexual activity. If they aren't sure if their child's been vaccinated, ask them to check in with their physician. Ask if they are comfortable if you do a medical consult to check in with that. Offer more resources on that so the conversation doesn't end there. And if they're wondering about cancer, you can go over some of the signs and symptoms of issues that are sometimes found in people with oropharyngeal cancer. Remind them they'll go through some types of other oral cancers that are not associated with HPV so that they can be more aware of their mouth and any changes. All right, feel free to contact me with any questions. And next we'll hear from Lisa Bennett-Johnson at Brigham and Women's Hospital. Take it away, Lisa.
Thank you, Rosie. And hello, everyone. I have no potential conflict of interest in relation to this presentation. And I'm going to provide an overview and recap key aspects of what we just heard from Dr. Vila and Dr. Wagner. I'll explain my role with the task force. I'll provide talking points for the dental hygienist. I'll touch on evidence-based resources for your practice and invite you to participate in our mission to improve HPV vaccination rates. So a few key takeaway points worth remembering. In the U.S., HPV is a complex emerging public health issue. And despite being recommended since 2006, HPV vaccines are suboptimally used, particularly when compared to other routinely recommended adolescent vaccines. While HPV vaccination is recommended at age 11 to 12 years of age, catch-up vaccination is recommended up to age 26 for females and up to age 21 for males. While most adolescents have received the first dose of HPV vaccine, only 43% of teens are up to date on all the recommended doses of HPV vaccine. Encouraging reminders to parents and caregivers to follow through with the complete number of recommended doses is critical to improving immunization coverage. The Massachusetts Oral HPV Prevention Task Force focuses on educating dental providers about the connection between HPV and oropharyngeal cancer. I serve as the Educational Outreach Coordinator, and I'm responsible for coordinating educational seminars and training sessions on HPV-related cancer prevention within the New England region. I also assist with the program evaluation process as we routinely assess how many providers we reach, and we measure the effectiveness of our efforts. What we've gleaned from much of the assessment data centers around a lack of self-efficacy amongst RDHs and CVAs regarding HPV education and vaccine referral. In fact, this aligns with current reports and peer-reviewed literature. So I'll share some key points to encourage and empower you and the dental team to incorporate HPV vaccine education in your daily practice. And I'd like to turn our focus to the dental hygienist for a moment. As we know, a substantial amount of dental hygiene education is focused on primary prevention and providing preventive procedures such as dental sealants and the application of fluorides. When we consider the impact of the dental hygiene extra intraoral examination, as well as tobacco cessation counseling, we have the potential to include HPV information and HPV vaccine recommendations within the education we already provide every day to our patients. And of course, this can easily be translated to any provider role when prevention education is offered. As Dr. Wagner previously mentioned, consider opportunities to educate about HPV infection prevention during routine preventive care visits. Maximize time during preventive care exams by highlighting the importance of HPV vaccination for males up to age 21 and for females up to age 26. Sharing this information with all of your patients will reinforce the importance of HPV vaccination for all young individuals. Steps towards self-efficacy. Everyone on the dental team must be comfortable with the topic of HPV vaccination for successful recommendation results. First and foremost, educate yourself on the HPV infection and the protective benefits of vaccination. Consider any level of discomfort regarding the topic, such as vaccination itself, the topic of cancer, sexual stigma, or perhaps something else, as these are potential barriers to your professional communication. Consider a more matter-of-fact approach, as Rosie talked about. Don't preach, and avoid getting into the weeds with the details. And be sure to include passive educational materials such as videos in the waiting room, posters, pamphlets, etc. And the Team Maureen Dental Toolkit is a user-friendly resource available at teammaureen.org, and I'll talk more about this in just a moment. Remember to support your recommendations with current evidence. Although the term evidence-based may seem overused, it's critical that you seek evidence-based information and material for yourself and your patients. Be sure to seek sources such as peer-reviewed literature and the Centers for Disease Control and Prevention website. In fact, the CDC is an excellent source for education on HPV, cancer prevention, and sexually transmitted infections. Additionally, other professional development options to improve self-efficacy for communication may include techniques such as motivational interviewing and active listening. Here is a list of additional resources on HPV and the oral cancer connection. So what are the next steps that you and your practice can take to include HPV cancer prevention education in a systematic way? Consider adding HPV cancer prevention education to your list of monthly action items. Review HPV cancer prevention education as a team, and although individual efforts are very valuable, the team effect can be exponential. Consider active role play to help staff become more comfortable with the basic message, and discuss and review progress regularly during staff meetings. Last and not least, the educational outreach that we provide is supported in part by the National Network of Libraries of Medicine, and assessment data is critical to measuring the success of our efforts. So we invite you to visit the Team Maureen website and download the free dental materials for HPV-related cancer prevention education, and to also take our survey. Team Maureen and the Massachusetts Oral HPV Prevention Taskforce has created a dental toolkit to provide dental professionals with resources on HPV vaccine. The toolkit includes a patient-friendly brochure on HPV vaccine and oral screening, talking tips for oral health providers to discuss the HPV vaccine, a poster advocating for the HPV vaccine, and a prescription pad that can be given to patients and used as a reminder to schedule vaccination. Finally, when you sign up for the toolkit, let us know that you attended the CDC webinar so that we can invite you to participate in a brief follow-up online survey. This will help us to know your thoughts and opinions about incorporating HPV education and the toolkit in your practice. Thank you all very much for your time and attention about this important public health issue.
Thanks, Lisa. Go ahead.
There you go.
Sorry,
Thank you. Take it over.
Thanks. Yeah, thanks, Lisa, and thanks to all our speakers. Obviously, lots of important work going on in Massachusetts. We have some time for a few questions. I know you've been typing those in as we've been going on. So if you have additional questions, I'd just like to remind you that you can ask a question by typing it in the lower left-hand corner of your screen. And now Catherine Martin is going to moderate the question and answer session. Catherine?
Yeah, thank you again, Tom, and thank you to all of our speakers. What a fantastic job. And I know I join my fellow participants, attendees, in thanking all of you for this great work and sharing how we can partner with our dental community to prevent this disease. So first of all, I wanted to remind our attendees that the slides and the broadcast will be available on the VIC Network site as well as the CDC YouTube channel, and we'll have some information after the Q&A about that. But I'd like to get to those questions so we can get as much information as we can out of our wonderful speakers. And we've got a lot of questions about the capacity or the availability of dentists to give vaccines, and I'm not aware of any states that authorize that. Can Dr. Vila or Wagner comment on that?
This is Rebecca. One state that I know of does allow dentists to vaccinate, and that is Minnesota. They allow dentists to vaccinate with the flu vaccine. They are required to have a training course and agree to some federal vaccination recommendations, but that is the one that I know that dentists can vaccinate. Massachusetts did allow dentists to vaccinate during the H1N1 2009 pandemic for flu vaccine, but at this time dentists cannot administer a vaccine in Massachusetts.
Okay, good. That's good information. I know in California there's been some discussion on this, and I'm sure there has been in other states as well. We've also been getting questions about that handoff of sorts. So since many dentists are not authorized to vaccinate or maybe do not have the capacity to store and manage that system, but we're encouraging them to be strong recommenders. Did you want to talk a little bit more, Dr. Wagner, about that handoff as far as dentists participating in referrals?
Sure. I find the most effective, there are two ways to help this happen. One is that dentists can go into agreements with retail pharmacies to host an immunization clinic in their office and then tell patients, however frequently that is, this is an opportunity to start your series or to get other vaccines in your office, but the pharmacist would be administering it. In terms of referring patients to other providers, I would recommend that the dentist be more proactive than just handing the referral to the patient. You can contact the provider to tell them to expect the patient, maybe even find out the date of the appointment if this is an appointment type of vaccination, and follow up after it's finished, similarly to how we would deal with a root canal referral or something else to make sure that something's completed before moving on to the next step. And so it's also a really good opportunity for dentists to be familiar with calling a pediatrician's office or a PCP or a pharmacist and help bridging the gap on these three branches of a patient's medical home.
And if I may add, this is Rebecca. In Massachusetts, we did expand the options for pharmacists to vaccinate down to 9. And so they have the option for preteens and adolescents, which HPV vaccination is the recommended age for. They can go to the pharmacy, so that it even has a better connection between dentists and pharmacists that they can refer to a pharmacy for easy access if needed, if they do not connect with their PCP.
Excellent. Several clinical questions about the HPV virus in particular, and one questioner asks about when, Dr. Vila mentioned about the virus clearing itself And one of the questions is about, does it go away for good or does it reemerge? Or is it kind of difficult to tell given our diagnostics?
So that's an excellent question. There are studies that show that the infection clears completely, but then it's unclear when we develop a second infection, which could happen by skin-to-skin contact. It's unclear whether that's a completely new oral HPV infection or if this is a reactivation of an old infection. So there are controversial data on this, actually.
And speaking of diagnosis, I know I was reading an article earlier this week about patients, and when they discover cancer, maybe it's through their physician or their dentist, but one gentleman was writing about how he discovered a lump on his throat, and that was already stage 4. And I was wondering if you could speak to that as far as the symptoms that don't show and how you use that in your education.
Yeah, so oropharyngeal cancers, which are different from oral cancer, again, unfortunately do not have any visible precursors lesions. So early detection becomes challenging for oropharyngeal cancers. But typically the symptoms are a persistent sore throat, difficulty swallowing, difficulty moving the tongue right and left. At a later stage, patients typically complain of also difficulty opening their mouth. There might be active bleeding, fatigue, and then the lump in the neck is a classic sign, but unfortunately that would be already at a later stage.
Mm-hmm. Right. So we're getting a ton of questions in here, so pardon me if I bounce around a little bit, but one of our questions is about, let's see, any anecdotal information on dental patients' reception of receiving these recommendations, whether it's about recommending that their teenager be vaccinated or if it's someone in the age range that you would consider recommending. I was wondering if the physicians and professionals could share what kind of response they're getting from their patients.
Sure, I can respond to this one. This is Dr. Wagner. In general, I've received the majority as positive responses with a general assumption of, can't we just do this now and here, rather than feeling negatively towards the recommendation or towards the vaccine. I found that since I anecdotally have reduced discussion on transmission and more focus on the virus and cancer prevention, most people are receptive. One thing to note is a lot of adults over age 26 ask about the vaccine and more information about that. That's outside the scope of this talk today, but providers should be prepared to help answer questions for older adults and cancer prevention as well. But in general, thankfully, it's been very, very positive and only takes 2 to 3 sentences to really get the message across.
Excellent. Anyone else want to comment on that? Great. Let's see. Oh my goodness.
I'd like to say one more thing if possible. I've seen some questions about how to educate fellow providers rather than patients, especially people who are concerned that their fellow providers might feel uncomfortable with this. And I find that's a different set of education. And since these slides and talk will be available, doing a shorter condensed talk like this is a great way to educate, because going over the pathophysiology of the high rates of cancers really helps drive the message home. And once that part is focused on, the other part of the vaccine and the patient education becomes a little more relevant to the providers. So I would focus on Dr. Vila's data on that to really show that it's an increasing and pretty serious problem.
Absolutely. One of the questions to any of our participants, especially about Massachusetts, wondering if you have seen, if you're aware of, or if you've seen an increase in completion of HPV vaccination rates in your state thanks to your efforts yet.
So this is Rebecca from the immunization program. So we continuously look at our HPV vaccination rates, and while Massachusetts is lucky that we are higher than the national average, we are still under the other recommended adolescent vaccinations. And so we are seeing an increase in Massachusetts in our HPV vaccination rates slowly but steady. If it is per se related to the dental project or the Massachusetts Oral HPV Prevention Task Force, that is hard to gain knowledge on. I think it's a combination of all of the efforts going on in Massachusetts, including our everyday interaction with pediatricians and other healthcare providers, our continuous education with all of those groups, and our site visits, our vaccine site visits, our AFIX webinars, and our AFIX presentations, and we have large pediatric and adult conferences every year geared towards immunizations. About 400 people attend each of those conferences where we focus on HPV as one of our main initiatives. And so we have a lot of different educational activities going on right now to increase HPV vaccination rates.
Yes, there's a lot. I'm really excited about what you're able to share today, and there are a lot of great resources in the community. And speaking of resources, I have a question about whether you're aware of any short training videos for dental providers that provide information on HPV, how to screen, but also, and then maybe separately, how to discuss. I know that can be very useful for folks to see that discussion going on and to have a trainer live. Anything among your toolkits on that, or are you aware of?
So there's no video in our toolkit at this time, but I do know of some other organizations that have been doing a similar type of project that have videos. The National AHEC, the Area Health Education Center, has been doing some work on dental providers, and they have a video on this topic, and so maybe that can be shared with participants afterwards. That's one thing that's coming to my mind. And if I may add, I saw one comment come in about the different age recommendations, why men and women and boys and girls have different age recommendations. And ACIP is actually meeting today to talk about the higher age standardization, and that is on the agenda. It's more to do with the path of the HPV vaccination and how the different recommendations came into play.
Perfect. Thank you so much for helping me out with this, because as you see, we've got a lot of great questions and they're all over the place. So, and I wanted to let our participants know that we would be reviewing these questions at the end and get answers to as many of these as we can following, because we think it's such a great opportunity. Evaluation, wondering if this collaborative intervention has some short, midterm, and long-term goals that you're tracking, and if you will be sharing those. Any of our presenters?
Yes. This is Rebecca again. We are trying to assess our success of this project, and that's why if you go to the Team Maureen website afterwards, if you could do a short survey that Lisa mentioned, take a look at our toolkit. And we do, at our larger presentations that we have done either collectively or individually, have done surveys and tried to really assess the gain in knowledge and then the application in practice.
Perfect, thank you. Regarding oral cancer risk and smoking, we had a couple questions about once individuals stop smoking, what the continued risk factor is, since we've seen from your slides that men and women who smoke and also are exposed to HPV have a higher risk. Wondering if you knew any data or could share anything about whether that risk substantially decreases after cessation.
So this is Dr. Villa. So there has been a decline in the prevalence of oral cavity cancers beginning in the late 80s because of the current decrease in smoking, which is the primary risk factor for these cancers. However, there has been an increase in the oropharyngeal cancer rates of HPV-positive oropharyngeal cancers, which are histologically, and as a type of cancer, there are two different types of cancers. So the HPV-positive one presents histologically differently for the HPV negative. The role of smoking in these cancers is that patients who smoke are at a higher risk also of developing a new oral HPV infection. If a patient stops smoking, the risk is reduced, but it still remains there. And it also depends on how much pack per day or pack per week the patient used to smoke. So the risk is different depending also on the quantity and the number of cigarettes per day. I hope it answers the question.
Well, that's a perfect wind-up there. We had a lot of questions as part of a really terrific presentation. I'm going to hand this back to you, Tom, to wind it up and thank our presenters again.
Okay. All right. Thanks, Catherine. Unfortunately, we're out of time. Usually happens with these kind of webinars because there's such good information. So I'm sure you join me in thanking today's presenters for sharing their time and expertise. And thanks to everyone for participating on the call. We hope it was helpful. Now, don't forget to complete the evaluation form that will automatically appear after this broadcast. Your thoughts and opinions are important to us. So we will be posting this webinar on the CDC's YouTube channel, as well as its website in the near future, as well as the slides will also be posted. So again, thanks so much for joining us, and that's the end of our webinar.